Everything is always easier if you hang it on a case. So I thought I would talk about the case of John to start off with. And then I think decision-making really hangs on prognostication and being able to make predictions about when the patient is approaching the end of their life. So one of the things is about being able to know that better. And whilst no one has a crystal ball, you can never know absolutely. You can certainly have indicators that point you in that direction, and there are certain things that should kind of start that kind of trigger process of perhaps I need to start those really difficult conversations with this patient. So there were 501,424 deaths registered in 2014. Cancer was the commonest broad disease group, but that accounts only for 29%. So actually, the majority of deaths are non-malignant causes, so 70%. And the commonest cause in men was ischemic heart disease. The commonest cause in women was dementia. And that's the top 10 for men and women from the Office of National Statistics. But the thing that slightly surprised me was that actually when you look at the list for women, cancer doesn't even make it into the top 5. So that was quite interesting. So the case of John. So this case is actually taken from my registrar training, which I presented as a grand round at that time. And so it actually comes from 2011, but I think you probably all have a John on your caseload at the moment. He's a 70-year-old man. He went into the Chelsea and Westminster Hospital, which is where I was training at that time, with an exacerbation of his heart failure and COPD, and he had both. He was wheezy, he was really breathless, he had really swollen ankles, and his exercise tolerance had gone all the way down. He was breathless, just kind of, walking room to room normally, and actually that had got as bad as being breathless just sitting down at rest. He was always sleeping in the chair. He already had oxygen at home. So this is a man with very, very advanced disease. His past medical history, I'm not going to read out, but was really, really long. There was nothing this man didn't have, basically. Multiple heart problems, multiple endocrine problems, chronic pain, just, everything was going wrong for this man. He was on 20 different medications. He lived with quite a frail, elderly wife, and she was not managing to cope with all of his care needs. And in the previous 2 years, he'd been in hospital 13 times. And these were not short admissions. These were admissions with heart failure, where they upped the diuretics and gave him renal failure, and so they dropped the diuretics, and he got breathless and edematous, and he ended up on an IV, and then they increased the diuretics again, and he got, and somebody came around and gave him IV fluids or something. So he spent ages and ages in hospital. So this graph is the number of days he spent in hospital per 3 months. So in one 3-month period, at the end of 2009, he'd spent 50 days in hospital. And the bit where he wasn't in hospital was when he was abroad visiting family, and then he came back and spent, months at a time in hospital. This man was just in and out, in and out. So he was already on maximal medical therapy. He was deteriorating during the admission, and they referred to palliative care. It was really clear that this man was dying. We went down to the ward, we got involved, we started the conversations with him and his wife, and, this is it, time is really short. He was really clear in saying that he wanted to die at home. We started all of the rapid discharge planning, but actually he was unconscious within hours and was then nursed on a personalised care plan and died the next day in hospital. And it just felt like a really unsatisfactory outcome all round. And I suppose that one question is, what might have been possible if we'd done a bit of planning in advance, and kind of what kind of planning are we talking about? And then I think this is a really interesting one, which I think shocks hospital specialists. In the space of 6 months, he had 24 different outpatient appointments. This poor, frail, elderly wife was bringing this sick man who couldn't walk from room to room at home up to the hospital to wait in outpatient clinics for hours at a time, more than once a week, every week, and he was spending 70 days of that 6 months in hospital. So that's even more outpatient appointments, and why the cardiologist didn't speak to the respiratory physician, didn't speak to the elderly care medicine physician, didn't speak to the diabetologist, didn't speak to the urology surgeons, didn't speak to the renal physician to say, let's amalgamate some of these. Do we actually need all of these appointments to manage this frail elderly man? I really have no idea, but it's a real example of tunnel thinking. And I think, particularly GPs and, community clinicians have a unique role in actually being able to see the whole patient and take that broad angle lens, rather than getting very, very focused on the one condition that you want to optimise, and I want to, make sure all the cardiology drugs are right, and then the renal physician comes along and says, oh, no, that's no good for his kidneys, I want all the kidney drugs to be right, and what about him, I suppose, is the message. I think it probably will improve as electronic notes get more common. And in that hospital, they had electronic prescribing, but they didn't have electronic notes. But you could access appointments electronically. So every time you looked to see if...
see the physical notes.
Yeah, absolutely. You should be able to see how many appointments they had. And it's one of those that didn't include all the x-rays he was sent for or the ECGs that the cardiologist booked. So this man probably was coming to hospital virtually every day of the last 6 months of his life when he wasn't an inpatient. And that just doesn't feel like very much quality of life. And I suppose it's just about where is the point of intervention. And I think some of it is maybe when you get that discharge summary, trying to book a bit of follow-up kind of soon afterwards and try and get in before he bounces back into hospital. But I accept that's probably very, very difficult for this particular gentleman. I had an interesting experience in the heart failure clinic with a patient that said to the cardiologist, so how long have I got to live, doc? And the cardiologist answered him by saying, you don't want to know that. I was sitting there in the room as a palliative care physician watching. And so it's one of those, okay. So anyway, she went out of the room to get the echo machine, because obviously, tests are fun. And I kind of said, so that's a really hard question to ask. What made you ask that question? And he said, well, I've got 150 racing pigeons and my daughter can't look after them, so I need to know when I need to get rid of my racing pigeons. I thought that was a really rational reason to want to know how long you've got to live. So I think sometimes it's very easy to presume that people don't want to know. But actually sometimes there are very clear, cognizant, pragmatic reasons that actually having this conversation, they start the conversation. So on average, the average GP will have about 20 deaths a year, and 1 or 2 will be unexpected, 5 will probably be from cancer, but the majority again will be the organ failure or frailty and dementia. I don't know whether anybody is familiar with this graph, but it's just a word to the wise that we are terrible at prognostication. And it's worth bearing in mind when you are prognosticating that doctors are consistently over-optimistic. So they basically went back to the referrers of 468 terminal patients with any diagnosis, but the majority did have cancer because they were being referred to a specialist palliative care, and just asked them to make a prediction about what the prognosis would be. And then they just followed the patients to see how long it was. And the diagonal is being right. And then they actually gave them a fairly wide leeway of plus minus 30%. And still only about 1 in 3 of the referrers got it right, or 1 in 4 really, just over 1 in 4. And so we systematically overestimate. The longer you know the patient, the worse your prediction is, and the more recently you examined them, the worse your prediction is. And I think that probably is about just having a bit of insight that doctors are people, and that people like patients, and that's okay. But actually just being aware that you probably need, whatever you think your prediction is, you probably need to kind of divide by 3, basically. I had one consultant supervisor who said divide by 7. So however many kind of weeks you thought it was, that's how many days it might be. So that kind of frightened me at the time. So I'm probably now over pessimistic, partly because I do palliative care. But I think it is just worth bearing in mind that we're not good at it, and we are consistently over-optimistic, although there is still a scattering of points below the line, so that we all have the stories of the family that you told only had a few days and then they went on for a few months, and that's embarrassing, but it shouldn't stop us having the conversation. So it's the why bother, and I think the why bother is the difference between the two pictures on this slide. So you can have somebody die in hospital, on ITU, attached to a ventilator and lots of tubes, having lots of tests and lots of medical intervention, and on their own, apart from their ITU nurse and all the machines that go ping. Or you can have the elderly man with COPD and the elderly wife with dementia actually being at home in bed, having a cuddle, and one of them dies. And that's the difference. And actually, if you do a little bit of this advanced care planning of assessing the individual patient's needs, offering advanced care planning discussions, not all patients are willing to or want to engage, but I think we probably underestimate the proportion of patients that want to have these conversations. And with good advanced care planning, we can coordinate care, prevent crises, prevent all those unwanted interventions, and hopefully get the right care in at the right time, and thereby prevent complex bereavements, which not all the time, not 100% of the time, but certainly they take up a huge amount of resource and cause a lot of suffering sometimes. So what is a good death? I thought we would just talk very briefly about what it means to patients and families, and it's the things that you would expect. It's being comfortable, free from pain, free from vomiting. Clear decision making is key. Having the opportunity to prepare for death, complete their life, do the things that they want to do, contribute to others. So actually even people who have a terminal illness want to participate in medical research, for example, and affirmation of the whole person, and meaningfulness, the opportunity to be seen as an individual rather than a number on a ward.
I have to say, I think tonight's presentation on looking at managing palliative care for patients other than just oncology patients was absolutely superb and awe-inspiring. And I think that what really struck home to me again is we are not having these conversations early enough. I appreciate that probably is a message that is sort of fairly constant throughout, but it's something we've got to be much braver about doing. We have got to have the courage to have these conversations with the individuals and their families. And clearly, in patients who are not just cancer patients, that may mean at very different points in their trajectory. And we have just got to start doing this.
The thing that really struck home was in the stuff about patients with renal failure is actually the risk in elderly people and elderly, slim, small old ladies about having inaccurate EGFR and creatinine levels, and sort of needing to factor that into your dosing alterations. And that's something that I think we're all very bad at, and I've seen a lot certainly in acute hospitals, that people don't think about that. And I think that's something that's a really good thing to take away and remember from today's session.
The key message I wanted to get across this evening was to try and give people some confidence in being able to have a clearer idea about when patients might be entering the terminal phase of their illness, regardless of whether that might be from respiratory disease, from cardiac disease, or end-stage dementia and end-stage renal failure. I wanted to touch a little bit on symptom control, particularly of breathlessness, because that's the big one in terms of respiratory diseases and cardiac disease. And I wanted to talk a little bit about altered medication handling in renal failure, and actually give people a few pointers in terms of having a bit more confidence to use the opioids other than morphine, and to not be fearful in starting conversations around advanced care planning a little bit earlier on, and hopefully thinking about the different kind of outcome in terms of quality of dying experience for that person and that person's family if you can start some of those difficult conversations.